So systems that enable people, enable caregivers to, they have protocols to keep everyone safe, but they have professionals that are enabled in their ability to notice and respond, and they're able to create these moments of deep human connection that transforms both the caregiver and the care receiver and makes care not something exhausting, but rather a renewable resource. And so how do we design systems in which people, clinicians, can come in as whole selves and create systems that do not overwhelm them with protocol, but enable them to be caring people? I think that's a fundamental point.
That was Dr. Victor Montori, today's guest on the other side of the chart. This podcast is where we explore the human stories behind the systems, the technologies, and the processes that shape healthcare. This is also a challenge to the people building those systems to design with the lived experience of patients and clinicians at the center. Our guest today, Dr. Victor Montori, an endocrinologist at the Mayo Clinic, author of the book Why We Revolt, and the founder of the Patient Revolution. He's an incredibly thoughtful voice in medicine today and a fierce advocate for careful and kind care. I am absolutely honored to have him on the other side of the chart to discuss everything from moral injury, industrialized medicine, minimally disruptive care, and his phenomenal movement, the Patient Revolution. Victor, welcome to the other side of the chart.
Thank you very much for having me, Jill.
Before we dive into the heart of this episode, I want to start with the way we begin most clinical encounters with a quick set of vitals. In this case, a few rapid fire questions to get a sense of who you are beyond the bio, a quick look at the other side of the chart. So, with that, if you're ready, my first question is, what's one thing you wish more people in healthcare would say out loud?
How about I don't know? I think it sparks curiosity and gets the conversation going, and those conversations are essential for care.
That's a great answer. I'm excited for our audience to learn more about careful and kind care that really challenges the system to do just what you're saying. Be curious. With that, I'm also curious to learn a little bit more about you before we dive in. What's one thing you do to take care of yourself?
Well, the easy answer is I try to walk as much as I can, and when I walk, I listen to books, and that seems a good answer. I then thought, well, I also try to spend as much time with family and with friends. So that seems like a reason. But nowadays people wear wearable devices, and so for a little while I wore one of those rings that tells you how you're doing, and it gave me one piece of insight. The time of the week where I'm most relaxed, where it seem to be most zen, if I may, is when I'm taking care of patients. So maybe paradoxically, the thing that I do to take care of myself is to take care of my patients.
Yeah, I love that. And that feels perfectly consistent with who you are and your book, your movement. So that makes sense. That's really phenomenal. Well, we know a bit about you from your vitals check. I'd love you to tell the audience more about yourself personally and professionally. Would you mind sharing a bit about your background and how your journey led you to become such a fierce advocate for care?
Well, I'm originally from Peru. That's where I went to medical school, and after finishing my medical school training there, came to the United States and was lucky enough to continue my training at the Mayo Clinic. That's where I've done my professional activity, both as a clinician and researcher, over the last almost 30 years. And I don't know. I think one can make up stories about getting bit by a radioactive spider or whatnot. But I don't have an origin story. I think it's just that, growing up as a professional in an environment like Peru at a time where severe poverty, hyperinflation, and terrorism disrupted the infrastructure for care, while at the same time in training, reading the medical journals and the textbooks at the time, and knowing what good medical care looked like and not being able to practice that. And then coming to the United States and being able to see all those resources available, and yet still some challenges in the ability to receive care and offer care, particularly for people with chronic conditions. I think that that sense of a distance between what should be and what is has been, I think, a major source of voltage for the kind of work that we have ended up doing, both as a researcher in clinical care, advancing patient-centered care, and as a care activist.
Thank you for that. Your personal story is going to provide such helpful context for the rest of our conversation. So, you've drawn a powerful distinction between what you call industrialized medicine and careful and kind care. I think many in our audience will relate to the tension between those two. Could you explain what you mean by each and how they shape the patient and clinician experience?
Yeah. I think that it's easier to see this when you're a patient with multiple chronic conditions. You come in for care. These are appointments that were scheduled perhaps without necessarily connection with the problematic human situation that might be affecting you now. They're part perhaps of a disease management program. They involve testing and assessments that are standardized for people like you. Your particular history as a person and how what kind of life you're trying to live now, and how that life is in some way interfered by your conditions or the treatments for your conditions, all of that is kept in the background. And what you are receiving really is not care, but you're being processed through by a system, particularly among the top systems that are really geared to actually provide access to this disease management strategies and quick throughput so that efficiency can be achieved. And that sense that you got, instead of receiving care, you got sort of processed
Mhm.
through, is, I think, a hallmark of industrialization, the pursuit of efficiency, of receiving care for people like you, but not for you,
Mhm.
the sense that you remain a bit of a blur to the person seeing you. And it turns out that it not only affects the patient who is being processed, but also the clinician.
Sure.
Clinicians like me show up to make connections with people, show up to make a difference in the lives of people, to be changed by our interaction with people. But something we cannot do if we don't get to appreciate people in their both their biology and their biography in unhurried conversations. So when we process people as clinicians, we also feel like we're not doing all of our job, and
Yeah.
we cannot care the way we sign up to care. And that has now received multiple names, like moral injury, or even at the end of that, burnout. So industrialized healthcare is this mode that, while might appear efficient, it really is not only financially unsustainable. We discuss it in politics every, when politics are saying every day. It's also environmentally unsustainable. We contribute significantly to greenhouse emissions and carbon footprint, but also it's humanly unsustainable. And so both patients, particularly patients with multiple chronic conditions that keep coming back to the system, and clinicians that care for them, experience significant struggle as they are trying to receive and give care. The alternative to that
Yeah.
is this notion of careful care, in which care is not for people like you, but for you. It not only pays attention to the diagnostic labels that determine what's wrong about your biology, but also pay attention to what is distinct about you, your biography. How come you've come to this point? How is it that your life is interfering with treatment, or giving the manifestations of disease a particular flavor? But also, how is treatment interfering or enabling your life as it is now? And then moving forward, what are your goals and priorities? And how are those shaping how we make decisions about testing and treatment? And then as you go to the point of life as a patient, how are you get supported to make that care fit with your life, and in a ways that are minimally disruptive, which is the part about kind care, which is when healthcare organizes itself in ways that are profoundly respectful of your time, energy, and attention, that you rather spend being a person rather than a patient.
Yeah. I love that. That framing, it really resonates with me. as a clinician, but also resonates with me as a patient, a caregiver. And I think for all of us that are just really caught in the grind of the system and this kind of industrialized medicine that you're describing. So, one of the assumptions that shows up in the system is this label of the non compliant patient. And I love this. You talk about this in your book, Why We Revolt. And this non-compliant patient term, you say it's common, it's problematic. And what I really love is that you offer a different way to think about patients who seem disengaged. I'd really love you to unpack that for our audience. I think it'd be really important for the various folks that are listening to this, especially those of us clinicians, because I just think it's a very different perspective.
Yeah, I think that the key insight is that particularly patients who experience conditions that demand their self-management, which might include all the efforts that you do to access care, to participate in healthcare visits or tests, and then the implementation of a routine of treatments in your daily routine. The first insight is that all of that is work. And for patients with chronic conditions, every estimate that I know puts that work at somewhere in the order of a minimum of 2 hours a day.
Wow.
And so it represents a part-time job for many people with chronic conditions or for their caregivers if they are
Yeah.
getting help. So that's the first thing we have to recognize is that by for some reason, and we can explore those that include not only therapeutic advances in medications that don't no longer require you to be admitted to hospital for someone else to administer them to
Mhm.
you, but you can self-administer to technologies that support that self-management and even digital technologies more recently that enable care at the point of life. All these things have this feature that they transfer work from the healthcare
Mhm.
system, from healthcare professionals to patients and their families. And one needs to mobilize a certain capacity to enact that workload on a daily basis. And that capacity is given by a sense of purpose, a reason to do things, a sense of resilience, which is, often people describe resilience as this idea of bending without breaking, but it's really about breaking and then putting yourself back together
Sure.
again and again and
Yeah.
again.
Yeah.
I think that's probably a better picture. Usually, not on your own, but because of the relationships that you have with people that care for and about you. It comes from physical health, from mental health, from financial health. It takes a lot of resources to do some of these things. It takes a lot of time to be poor. And when you're alone, so social resources, when you're alone or you're poor or both, and you have some mental health challenges, any task becomes incredibly difficult to orchestrate, articulate, and make happen. Of course, if the lack of disease control is making you sick, then obviously being physically ill also reduces your capacity to do the work. And so you can imagine vicious cycles by which a patient shows up with markers of disease control that are not optimized, and the clinician responds by intensifying the treatment, making in that way more demands on that limited capacity, which is limited by the fact that the disease is not well controlled. So now the patient cannot enact that treatment, continues to be sick, and now we have probably further intensification. And so that becomes frustrating for patients and frustrating for clinicians. And there's another angle to this. So the idea of non-compliance, or non-adherence, which is a bit of
Mhm.
a mental dead end, where
Yeah.
if I'm told a patient is non-adherent, not compliant, I'm thinking I'm not going to be able to help this person. It can be switched to something that is basically an insufficiency of capacity, that the workload that has been asked of the patient and their family exceeds their capacity to implement. And so the job is really not so much to intensify the therapy, but to provide more support and right size the therapy to the
Mhm.
capacity that the patient has.
Yeah. Yeah. Thank you. I really love that reframe. And that's perfect segue to another concept that you champion. And it's this concept of minimally disruptive medicine.
Mhm.
Could you define that for the audience and then share some examples of how it's working in practice?
Yeah, so minimally disruptive medicine is the explicit effort to actually develop plans of care for patients that are, set to advance the patient's goals and priorities. But in doing so, to pay close attention attention to the demands that that plan makes on people's lives, so that you at the same time try to minimize the burden of treatment, try to impose on the patients the smallest possible healthcare footprint on their lives. And turns out there are a number of developments that had to move in that direction in order to take care of patients well. Probably the most remarkable example that is widely known are HIV clinics, specialized HIV clinics like Ryan White HIV clinics in the United States. These are clinics that, for the most part, have evolved in the same way. When the treatments for HIV/AIDS was incredibly complex with multiple medications, complex administration procedures. Clinicians that took care of those patients and those patients were able to quickly realize that in order to orchestrate that treatment, basic needs have to be covered, things have to be well organized and choreographed. And so these clinics evolved to have on-site, sometimes food,
Gosh, yeah,
on-site prescription refills.
sure.
They had social workers and pharmacists working on site, and they gave the patients a bit of a one-stop shop in order to ensure. And even if the night before, in many of these clinics, they had a member of the staff call the patient up the night before and say, "Are you going to be able to come? If not, we'll send you a taxi, or nowadays will
Yeah,
be an
yeah,
Uber or something like that,
yeah.
and make sure that you're going to be able to come." So all of that, you don't see that in a diabetes clinic, you don't see it in a COPD clinic, but the HIV clinics evolved that because adherence to that therapy
Yeah,
was
it's
essential for
critical.
survival.
Yeah, yeah, yeah. Oh, I love that. Yeah, amazing.
So that organization of care really was imposing the least amount of work on patients, and as a result, enabling them to survive.
So that brings us to another thing that you started to touch on, but you're also a leading voice in shared decision making. So tell our audience about how you define shared decision making, and why that is a powerful tool. I think it really is in line with where you were going with listening to our patients, because that tool is really about listening and collaborating with our patients.
I think you have it exactly right. It's so much about learning who the person in front of you as a clinician is, the other side of the chart, and recognizing that there's a whole world, there's a whole life playing out. There's a whole drama of that life playing out, in which our words, our expressions, our warmth, our kindness, our compassion, our technical expertise, our prescriptions are all going to now interact chemically almost with this other life. And so it's delicate work. And shared decision making is not consumerism. It is not about, let me show you the three different kinds of medication we can use, and then you choose the one you want. Nobody wants to be in that room or wants to pick up a medication. It's not about choosing what people want. It's not about choosing often. What it is a method of care. So shared decision making is the way, it's a method by which patients and clinicians choose to work together on addressing a particular problem and identifying in the process a way forward that will make the situation of the patient better. So sometimes that involves considering alternatives and identifying the pros and cons of each one and seeing how they match the preferences and values and circumstances of the patient. But there are other ways of doing that together. Another way is to address conflicted positions. Nowadays, it's not uncommon that patients come in with requests for tests or treatments they've seen on social media, tests or treatments that perhaps you as a clinician feel strongly will not be in the best interest of the patient. So now you have two positions that are at odds, and the process is not really to provide more education. Perhaps that's helpful, but it won't be the main thing. Or offer choice,
Mhm.
perhaps helpful, but that won't be the main thing. The main thing is to negotiate between two positions that have come apart to come up with some negotiated settlement that allows you to move the situation forward. Completely different method. The most common form of shared decision making that happens all the time is problem solving. I mean, those are of our colleagues who work in the hospital. They have to do with every admission. They have to solve the problem of when is the person going to go home?
Hmm.
And will the home be ready? Will this person be ready? Will the family be ready? That this discharge planning sort of process that is very common is usually a situation that is addressed through a shared decision-making dynamic between the nurses, the other physicians, the patient, and their family. Social workers sometimes are involved. So there is not a one-to-one often. It could be a whole team. In chronic disease, like diabetes, for instance, that's the most common kind of shared decision-making. And then at the end of life, choice or negotiated conflicts, conflicted
Hmm.
positions, or problem solving may play a role, but there's a different flavor, a different kind that emerges at times of transition, which are forms of shared decision making in which you're interested in the care being an expression of the person's voice. So that, for instance, at the end of life, this experience they're having, this situation of ending their life, is associated with some meaning, with some insight, and that what we do together to get through that trance is, which will be the last page of the book of their life, is written with their own handwriting. And that is a different kind of shared decision making, all of which are just methods of care that are, collaborative and seeking to advance a patient situation.
Yeah. Thank you for that. Let's zoom out for a moment to the system level forces that really shape how care is delivered. So, we're living in a world today, primarily fee for service, but we also have value based care models. So, talk to us about how these payment systems support or get in the way of careful and kind care. In your book, you talk about something called Goldilocks care. Can you tell us what that looks like and how do we get there?
Yeah, I don't know, because if I knew, then this would be the only thing I would be doing. But I think it's an invitation for creativity. When I wrote that book, Why We Revolt, I was thinking of my experience in Peru and my experience in the United States. But I was actually quite surprised to see the book do very well in places like Australia or Canada or the UK. I mean, think about it. The first translation was in Italy. The second one was in Spain. The third one, which was released a few months ago, was in Greece. All of
Huh.
these are places with different financing of the system. Most of them have a single
Single
payer
payer.
system, compared to Canada, which has almost universal
Mhm.
private delivery, even though it's public pay. Most other places have public pay and delivery. And so these are all very different models. In Canada, the again, public pay, private delivery, almost all of it fee for service. And one does not necessarily see the overuse of tests and treatments that sometimes is obvious in fee for service environments in the United States. So there seems to be something particular about not just the model of payment, but sort of what is driving professionals and the organizations they work for. And so another observation that people often make is, you consider for-profit healthcare organizations, which are, again, mostly unique of the United States and countries that imitate our healthcare system, and also nonprofit healthcare organizations, and sometimes it's hard to tell the difference.
Sure.
And so there's something else here that it seems to go beyond the models of payment. And then finally, I mean, value-based payment models, have in general had, incomplete success, in part because they have to coexist with fee-for-service models within the
Mhm.
healthcare system, the same system, which makes it very confusing for everybody in there. Fee-for-service could be very simple in terms of administrative complexity. And then we are so concerned with fraud and abuse that we provide overlay and overlay of documentation. And I wonder really if it is the model, fee for service versus value based, or is it everything else that we wrap around those models that
Mm.
makes healthcare incredibly expensive, incredibly bureaucratic, and where these issues of how do you pay for it come into the point of care and interfere with the
Yeah.
ability of patients and clinicians to care for each other. Again, once you look around, you realize there are other countries that are doing fee for service, and they're doing fine.
Hmm.
And there are other countries. Now, what is universal is everybody wants to reduce costs.
Right.
And inflation that is driven by, more conditions that can be diagnosed, more tests to diagnose more
Mhm.
conditions, diagnosing conditions earlier and earlier, and then having more treatments to offer people has to be more expensive simply because of the expansion of the repertoire of diseases and treatments that we can now care for. But if you are in a system where everybody that interacts with care has to walk away with 10, 15, 20% off the top as profits, by the time you end up at the point of care, there's very little resource
Yeah.
to care for people, and that's universal in countries that have a, single payer public pay system. The problem is not so much that there are so many people profiting from the system along the way, is that policies of austerity have actually depleted the system from the resources that it needs, and the way you perceive it, the way you feel it, is at the point
Mhm.
of care. And back at home in countries like Peru, it's a combination of the country being poor, the managers being incompetent and corrupt. There's significant amount of waste and limited attention to quality, and all of that, either by wasting resources or misusing them or profiteering, all of that leads to limited resources at the point of care.
Yeah. Oh gosh. Yeah. So much to think about and so much work to do. All right. So you've also written about industrial friction and how that gets in the way of the real partnership between patients and clinicians. Tell us about where you've seen bright spots and where do we still have opportunity or, maybe a long way to go.
Yeah, no, um, everywhere I go, people approach me with, horror stories that confirm the diagnosis and the story. But they equally exciting is when I hear people who have experienced something different. The first observation is that for some reason, the most meaningful experiences of care occur when somebody goes out of their way to care for someone. And this could be, the nurse that on the way home notices that an old man in the room is trying to desperately connect through the iPad to see their grandkids' graduation. And rather than go, stops and tries to help. I was just at a conference where the person that spoke right after me was telling the story of his sick child, and for him, he told a couple of stories of these moments of connection. One was when, after a very hard discussion with the clinicians about their kids who had cancer, he and his wife had gone downstairs to the main floor of the hospital where there's a coffee shop, and they had arrived at the coffee shop as the doors were closing and the lights were coming out, and so they turned around without coffee, but the doors opened, and the barista from inside the coffee shop called him back and said, "Oh, I've seen you. You've been here for a month.
Gosh.
You look like you need a cup of coffee. Come in." So she turned
Yeah.
everything back on and prepared them a cup of coffee, and so she noticed and responded, and that's the key thing. So, and she obviously disobeyed the constraints of the hours of operation of the shop. Another story was a nurse that wondered after a month, this kid in the ICU, is there a way of make sure that everybody remembers that this is a boy that has his own thing, and says, "Oh yeah, he loves Mario Brothers." And so the next day, the nurse shows up with a bunch of cutouts and things, and so now everybody knows this kid is the Mario Brothers kid. And then when the kid needed to be rehabilitated, he hated to go in because he had to learn to walk again and all these things, and he was embarrassed and so forth. The therapist made a course in the rehab gym. Made a course, and with a phone made the noises of the Mario
Oh,
Brothers thing. So
so
every
cool.
time the kid that he exercised had
Right.
the noise of the coins and all that. So what are these people? What are these
Little
people
things.
crazy? What are
Yeah.
they doing, right? And what
Yeah.
they're doing is they're going out of their way. So systems that enable caregivers to, they have protocols to keep everyone safe, but they have professionals that are enabled in their ability to notice and respond, and they're able to create these moments of deep human connection, that transforms both the caregiver and the care receiver and makes care not something exhausting, but rather a renewable resource. And so, how do we design systems in which clinicians can come in as whole selves and to create systems that do not overwhelm them with protocol, but enable them to be caring people? I
Yeah.
think that's a fundamental point.
Yeah. Yeah. I love that. Well, I think it's only appropriate to close with a discussion of your broader movement that you've sparked. So tell the audience about the patient revolution, what inspired it, and what kind of change you're hoping to catalyze.
Yeah. So the patient revolution is one of many organizations now who recognize this difficulty with healthcare, this industrialization. Our focus is not to drive reform of industrialized healthcare. We really are interested in fundamental change. So we call it the patient revolution because not because it's a cute branding, but because we really think that it's important to turn away from the industrialization of healthcare. We don't think that that's how you actually do care, and you move towards careful and kind care, as we discuss. And our model of change is the notion that we can't want the same healthcare for everybody everywhere around the world because every location and every situation is different. But we want everywhere for careful and kind care to thrive. And so we have care activists all over the world. We have in every continent who are acting locally with colleagues, with patients in a multidisciplinary fashion to make a difference where they are within their sphere of influence. How do they gather the courage and the know-how to do it? Well, that comes from being part of a community. So as an organization, Patient Revolution hosts and enables a community of care activists globally. We have a school. We have courses that people can take. You can become a fellow of the Patient Revolution and not only learn these things, but also offer them where you are. And then we have a greenhouse where we try to develop innovations for use at different levels, from the point of care all the way to policy, that equip these care activists with material that they can use to make a difference where they are. And the Patient Revolution is just a very small backbone organization that keeps these things going. People can learn more about it by going to patientrevolution.org. My goodness, we welcome any kind of donation, but more importantly, we want participation. We have patients who are fellows, we have clinicians who are fellow physicians, nurses, therapists, psychologists, pharmacists, we have designers, we have engineers, we have lawyers. Every walk of life is, at any point in time, we will either be care givers or care receivers. So a revolution of care is everyone's business. And so the patient revolution is one opportunity that we've been able to build over the last 8 years that enables that participation globally. And so I'll invite everyone to join and to participate and make a difference through our organization.
Thank you for this powerful conversation. And for the revolution you're leading, your work is a reminder that healthcare isn't just about delivering services, it's about building relationships, honoring humanity, and creating space for care that is both careful and kind.
Thank you, Jill, and for this opportunity, and best of luck to you.
For those listening, if this conversation resonated with you, if you've ever felt the tension between what care should be and what it too often is, I encourage you to learn more about the patient revolution at patientrevolution.org. And as always, thank you for joining me here on the other side of the chart. This show is about the human experiences of healthcare and about challenging those of us building the future of medicine to do better with patients and clinicians at the center. If you found value in today's episode, please consider subscribing, leave a review, and share it with a friend or colleague. It helps others find the show and helps move these conversations forward. And stay tuned for episode 5, where I sit down with Pranam Ben, CEO of The Garage, to talk about the intersection of data, design, and human connection in healthcare technology. You won't want to miss it. Until next time, thanks again for listening. The Other Side of the Chart is a production of G. Berg Productions, produced, Hosted and sound editing by Dr. Jill Goldenberg. Music by Relaxing Motivational Corporate by Fretbound. From Free Music Archive, licensed under Creative Commons Attribution 4.0.